Welcome to another Facebook Live from UC Davis Health. I'm Rick Cushman, and today we are talking robots. I'm with Dr. Bahareh Nejad. She's an associate professor of obstetrics and gynecology and the medical director of robotic surgery at UC Davis Health. And she oversees the whole robotic surgery program, although not every tiny little thing about it. But we are here with a whole lot of new exciting news today. Dr. Nejad, thanks for being here. Great to talk to you.
Thanks for having me.
So, I am actually a former robotic surgery patient, and I do have a complaint.
Uh-oh. Let's hear it.
I can't find my scars.
Exactly.
I thought it was going to look cool, but I got no scars.
Yep, that's our favorite complaint. Very small incisions.
Yeah, they went away almost within a year.
That's amazing.
Yeah, so there's one thing about those. So these are pretty exciting times here. But before we get to that, and when we talk about surgical robots, we don't really know what we're talking about. I mean, I think a lot of people probably think Megatron from Transformers. So what do these things look like, how robotic are the robots?
Well, the robots actually are quite large. So it actually, visually they are, luckily here we have very large operating rooms at UC Davis Health, so it's really nice because our ORs are large. But what they look like is a tall structure with literally arms that can reach out and attach to ports, which are little tunnels that we place in the patient for the instruments, and then they're able to move those instruments. And so it makes it really great because the robot allows us to have 360-degree range of motion, which are better than our own wrists, and then it completely reduces the tremor. So
explain a little bit about how they work. So what happens what does a surgical robot do in terms of, let's start with in the surgery itself. How is it different from making a slice and going in and cutting around?
Yeah, so if we make a big incision in the patient and then we have our hands in the patient and then all these different instruments versus we put these trocars or these ports, these tiny tunnels, which are the incisions are about 5 to 8 millimeters in size. So we make a few of those little holes, put the little tunnels in so the instruments can go in and out and the camera can go in and out, which is really nice. And then we attach the robot to that. And then we actually unscrub from surgery. We do that all ourselves as the surgeon, and we sit next to the patient in a 3D console. And when we're sitting in that 3D console, I can see everything in 3D because the camera's inside the patient, and I can move the instruments, but I'm sitting right next to the patient.
And how do they move? Are they joysticks? Are there your hands in with hands?
Yeah, so there are these tiny little things, and they just take 2 fingers, and we just move them around. And then we have foot pedals for our energy.
Oh, wow.
Yeah, it's really cool.
So after my surgery, I was actually at a clinic where they were sort of saying, get tested, go this, and I was playing with one version of these things,
yeah.
and the one little tiny movement, they had both great dexterity and just, it was like learning them the first time you've ever learned how to use a mouse. Many people, that was when they were born, but for some of us older folk...
Or video gaming.
Yes, or video gaming.
Yeah.
So how hard is it to learn, and how much training do folks get to learn that dexterity?
Well, we actually do a lot of training. So what we do is usually do on-site training and sometimes off-site training. And so luckily we here have a simulator program also. So we have what's called a backpack simulator. So you can sit on the robot without a patient and do all kinds of movements and game-like strategies that mimic surgery. Mm-hmm. And you can do that to warm up for surgery, and you can do that to train for surgery. And then we do twice a year full, robust training programs that are week-long. We have one next week where we train our nurses, our surgeons, our resident surgeons, and everybody so that before anyone's actually operating on a patient, they've done extensive multi-week training sessions. Mm-hmm.
So it gives them your ability to move the hand. You have a screen. Is it magnified?
Yeah, so when we're in the 3D console, it's 10 times magnification on the camera, and then we also see in 3D. So we can see tiny little blood vessels to use energy on them before they start bleeding. We can dissect in really finite spaces that we wouldn't actually be able to do with our own hands.
What do you mean by use energy?
So when we see a blood vessel that we don't want to be there and we want to separate an organ from the body, we use energy or literally electricity to grasp it and burn it and then cut it. And wow. That's how we minimize blood loss. And we can do that with other types of surgery also. But the nice thing with robotics is that our human hands are actually too big to fit in some of these small spaces. So we can do more nerve sparing and have less blood loss because we can see much tinier things.
And, some old school person who doesn't know how to use a mouse that might say, but what about that surgeon, the classic, the surgeon with the steady hand, and that's what we always relied on. How does this compare to that classic surgeon?
Well, we still need those. So we still need those big incision surgeries sometimes. But ideally, if we can do the surgeries through the small incisions, then our patients can oftentimes go home the same day or the next day. They get back to their lives faster. They get back to their families, to their job, their hobbies, their activities faster. We decrease their infection rates. We decrease their blood loss. We decrease the amount of time people need to stay in hospitals, which nobody really wants to be here for a long time if you can get back to your life faster. So ideally, by making all these tiny incisions, we're giving them less pain. They're taking much less pain medicine, which is very nice. Mm-hmm. And so all of those things, ideally, our robotics program is trying to help our patients get back to their lives faster and have the safest outcomes.
Yeah, but they don't get a scar.
It's really nice. Yeah.
So and that steadiness is the I imagine the robot's probably even more steady than that steady surgical hand.
Absolutely. So the robot helps us with tremor reduction, and luckily most of us don't necessarily have a tremor. But if you're in a very long surgical case, in theory you could have one.
Robots don't get tired, do they?
They don't get tired. So it's a machine. It's not a human, and so it doesn't get tired. It reduces the tremor. So it's very nice for us.
Okay. So, do you deal with patients differently when somebody is approaching a surgery or at post-surgery? I mean, how do you deal with a patient that may or may not get a robotic surgery?
Well, when we counsel patients about surgery, we talk to them about all the options of the ways they could have surgery. And we say, I could do this robotically, I could do this open, these are the pros and cons. And the patient is involved in that shared decision-making, which is really important. Mm-hmm. But usually we say, we want to do your surgery in the most minimally invasive way possible. Whatever type of surgery that may be. May it be for a colon cancer surgery, a throat cancer. For me, it's large fibroid surgery, so women with endometriosis or large fibroids in their uterus. Whatever the surgery may be, we say, what's the most minimally invasive way we can do this to get you back to your life faster and decrease your complication rates?
So for the patient, they have probably the same walk up to a surgery, right? It's
the pre-op.
Yeah. Mm-hmm. So none of that would be different, but their recovery is the part and plus what's going on there. For the OR team, what's different there?
It's completely different once you enter the operating room. So our OR teams, when we do robotic surgery, are specifically trained to work the robotic systems. We have 3 robotic systems that are exactly the same, and then we have our new single port or SP robotic system, mm-hmm. Which we just had delivered last week. But we have all of those robotic systems in the same surgical pod. So all of our nurses, equipment specialists, clinical engineers are all trained on the systems. The surgeons are trained on the systems. Our residents are trained. And so ideally, we have everyone on the same page so that we have a team approach to the operation because we feel that that's the safest way for the patient.
And what looks different? I mean, we sort of all have an image of it. I've been in a couple operating rooms, but I've watched a lot of television. But this image of the doctors over the patient, the nurses right behind them, with all the assistants. What is it similar in a robotic surgery?
It's similar to start. So we're all scrubbed into surgery. We're all wearing those blue gowns like you always see with the hats and the masks and everything. And we're all standing over the patient. The patient's lying in the bed right in the middle of the room. Mm. And we're all scrubbed in a sterile field, just like we always are. And then instead of making one large incision, we make a bunch of tiny incisions, anywhere from 1 to 5 tiny incisions. And then we put those ports in. So instead of our hands being in a big incision, we put those ports I was talking about, which are those tunnels mm-hmm. that go through the skin. And then we attach the robot to the patient. Then the assistant stays scrubbed in at the bedside. And then the surgeon scrubs out, and then we go sit in our 3D console. And then we move those instruments alongside the patient.
So what are the assistants doing or keeping an eye on while they stay scrubbed in?
Sometimes they're doing suction, and sometimes they're changing instruments in and out. So we say, I'm going to change this instrument in and out. It's attached to the robot, but it takes a special person who's trained to exchange those instruments for us and to give us what we need in the operating field.
Got it. If you are just joining us, by the way, I'm with Dr. Bahareh Nejad. She's the medical director of robotic surgery at UC Davis Health. We are talking about robots, particularly robotic surgery, and we just got a new one.
We did.
Yeah, so tell us about that.
We are very excited here at UC Davis Health about having our new SP system. It is the first one in California. It is the second one on the West Coast and one of only 20 released in the world right now.
Wow.
And so it's called the SP robot, which stands for single port. And so
wow, that's sophisticated.
It is.
Yeah.
It's really fancy. And so it's a 2.5 centimeter incision. So it's very small, and you do the entire surgery through 2.5 centimeters. And actually, for tonsillar cancer or throat cancer, it's done just through the mouth,
wow.
transorally with no incision. And so we would love to proceed in doing more natural orifice surgery, meaning a hole that you already have.
Right.
And then if we can't, then doing single port surgery, which is a 2.5 centimeter incision for your whole surgery. And then the next step would be multi-port. So
how would the single port surgery work? I mean, why can you get away with doing that? How do they just make one incision? Since we need the camera, we need the cutting pieces, we need to get stuff out of there.
Yeah. So amazingly, in that single port, it's one instrument that comes into the patient through one port, goes through the skin, and then the instruments and the camera all come out.
So they're
through
in
it.
like this tunnel. Like this is, you can see behind us. That's
right.
what that is, right?
So it actually has 3 instruments and a camera all coming out through a 2.5 centimeter instrument.
This is slightly magnified.
Yeah. Yeah, so 2.5 centimeters, and then 3 instruments can go and converge on the target organ that we're operating on. So we'll be starting with urology surgery, so prostate surgery,
right,
and or throat cancer.
That's me. So I was a prostate surgery patient, and obviously I had my prostate removed. So I think I remember it was disconnected. Once again, I've watched a lot of television. It was disconnected, chopped up into smaller pieces, and taken out through the holes. So if you've only got this one port, how do you get it out of there?
And so, well, there are different ways. Sometimes you put a different tiny hole, like a 5 millimeter hole, to put a separate camera in, and then you can take a bag and put it in that 2.5 centimeter hole, and then bring out the specimen that way.
Wow! Wow! All right.
Yeah, we have a lot of tricks up our sleeve.
That's pretty cool. So, and then we've got 4. What's our? Give me, rather than me guess, what's our inventory on?
We actually currently have 6 robotic systems. One will be traded in, and we will end with 5 robotic systems. We have a brand new robotic system for spine surgery, for some spinal surgery procedures, spinal fusion procedures, and then in addition to that, we have 3 XI robots, and now the new SP robot.
And that makes us leaders. You talked about the single port as only the second on the West Coast. I happen to know that the spine surgery were the first academic health system on the West Coast to have one of those. And then those are also the most advanced multi-port systems as well.
So they're the 4th generation products. So they're the latest products that have ever been released. So
let's talk about our role as we're an academic health system. So is this our responsibility? I mean, is that how you folks see it? That we are leaders, that we help train folk?
Absolutely. I think for my job, so I help train the residents and do the teaching programs. We have a University of California collaborative where across all of the UCs we work together to design training programs, because we truly feel it's our responsibility to all of the community to train our surgeons at the highest level possible with the best equipment and put them out into the world, because they're going to leave us and go get jobs elsewhere, and we want to make sure that they're well trained. And then we also want the safest care for our patients, and we feel that as long as we're teaching, we're on the forefront of technology. And at UC Davis Health, we definitely are on the forefront with all of our new robotic systems and our very, very deep robotic program.
How many surgeons do we have that are trained?
We currently have over 20 robotic surgeons in 6 different specialties. Our areas of growth right now, we're doing liver and pancreatic surgery, we're doing hernia surgery robotically, we're doing thoracic or chest surgery robotically. We're growing in many different areas. And then, of course, as you mentioned, prostate surgery, gynecology surgery is what I do for hysterectomies. We do gynecologic cancer surgery, urology cancer surgery, throat cancer, I mentioned before. So we are very broad in our range of robotic surgeries, and we all work together.
So obviously, as you said, there's some surgeries that you can't do with robotics. So you just listed a whole bunch. Are there guidelines? Are there some that are sort of could go either way?
Well, some of them are already standardized across the country. So prostate surgery, hysterectomy surgery, those have been done for over 10 years robotically at many different institutions. We were on the forefront of that, but that is That's something that you see in other academic centers also. But then at UC Davis Health, we want to be on the forefront on a lot of the procedures. So the SP, the single port robotic systems, we are on the cutting edge of that. So there are hepatobiliary, the liver and pancreas surgery programs, and our chest surgery programs. Those are ones where we're kind of pioneering the way. And definitely with the throat cancer surgery also. So there are certain areas where our surgeons are really taking the lead, and that's what's really exciting here.
We talk a lot at UC Davis Health about, it is our job as an academic medical center to lead the way into the future. And, as here we are doing what amounts to a television show off of a cell phone that people will be able to watch forever. I mean, clearly the technology changes daily around here, around everywhere. So how do you stay up with it? This is something that we're supposed to be, we feel it's our mission in essence to be helping people figure it out. But I mean, this is the future of medicine. Technology the use of technology is the future of medicine. How do you guys, with something so sophisticated as this, sort of stay up on what the changes are and the adaptations that is necessary throughout the system?
That's a really good question, and it's not easy. And so what I would say, it's a two-way street. So a lot of times technology comes to us, and they say, look, we want you to pioneer this. We want UC Davis Health to be the first in doing this, because we want it to be an academic center. We know you guys know what you're doing. We know you'll vet out what's safe. And then we have to decide, is that the right choice right now or not? And we have to look at the studies and look at the research and the safety profiles and decide how we want to move forward. In addition to the fact that we are the leaders, so we are the speakers, we are the ones who go to the meetings, we're the ones who conduct the research. And so we go to national meetings, international meetings, we see what's out there, and then we bring it back here at UC Davis Health, and then we teach it to the community also. So our surgeons are out there everywhere.
In essence, you're the doctors who teach the doctors.
That's right. We are the doctors who teach the doctors. So we have to know what's going on and what's coming.
Okay, so for something like this, how much support does the academic system, does UC Davis Health give you guys for this sort of thing?
Well, we're really lucky because we really find here that it's a team approach. And so from our administrators all the way down to our staff and in between our OR leaders, all of our surgeons, our nursing teams, we find that we have a lot of support because everyone wants to be ahead. And everyone says, if we're going to do robotics, let's do it big. Let's make sure that we do it all the way. We don't want to do it halfway. We want to make sure we have the best systems available. We don't want to go get the older systems. We want to get the newest and best available data. We want to get the best equipment, and we want to do what's best for our patients.
So once again, we are talking robots, or more specifically robotic surgery, with Dr. Bahareh Nejad. She's the medical director of robotic surgery at UC Davis Health. If you have any questions, please ask them. I promise I won't answer them, so you'll get real answers. But I do have a few more questions myself. So how are robots received by patients? Is there first whoa, I don't want a robot?
Sometimes, but very rarely. I think that sometimes people come in and say, that makes me nervous. I don't want the robot doing my surgery. And I say, well, the robot's not doing your surgery. That might be something, 10, 20, 30 years from now. But currently, the surgeon is doing your surgery. The robot just allows us to see better and to move better and to have the tremor reduction and have the 3D and to decrease surgeon fatigue. Things like that. That's what the robot helps us do. But we just try to explain to our patients. Sometimes we show them videos. Sometimes we show them pictures and we go over it. And usually once we explain, the patients are completely on board when we tell them, but you could have these tiny incisions. You can go home the same day and take very little pain medicine. They're like, I love robots now. And so usually we can get them on board just with education.
Do you warn them they won't get to keep a scar?
Well, I'm sorry, your scars will be minimal.
And how about in the medical community? Is there general acceptance? Is there resistance in any quarters?
I think that there is resistance in some areas with laparoscopy, and so very advanced laparoscopic surgeons. And laparoscopy means you also make very small holes and also put in those ports or trocars, like the tunnels for the instruments. But instead of the robot attaching to those trocars or instruments, you use your hands, and you don't have that 360-degree range of motion. You don't have the tremor reduction. And they say, well, why do you need a robot when you can just do it all laparoscopically? And my answer is that there are lots of things we can do laparoscopically, and there are some things that are just too difficult. And the robot allows us to minimize those big incisions and to do them robotically, and where laparoscopy still has its place.
So I have to imagine down the road somewhere, because we talk a lot about that here too, is that AI will start to play a role. which is, in simple terms, not like it's going to think for itself, although that may be coming too, right with the flying cars, by the way.
Maybe.
But that in essence, a geometric progression of analysis, I guess, is a way to think about it, which is that AI will be able to look at a situation that the robot sees and that you see, and compare it to all these other incidents, and then help you with decisions that you would make.
Mm-hmm.
Is that something that's coming in surgery?
I think when I think of what could be next, I think, well, that's got to be what's next. But I don't think it's coming anytime soon. Because I do think that you'd have to enter millions of data points into a computer system to say, as a surgeon, we are very humbled every day because no two surgeries are alike. And so when patients ask me, how is it going to go? I say, well, based on my experience, I'm going to navigate it so that it goes well.
Right.
But there are always things that I can't anticipate.
Right.
And so with AI, that would be the concern, right? So we have to figure out, artificial intelligence-wise, how can we anticipate the unknown?
Right. This is the driverless car thing.
That's right.
It's taking all that experience, but it didn't have the time where the guy in the motorcycle jumped the curb and went over the tree.
You can't replace experience with everything.
Right.
Yeah.
Right. So would it be possible, a guy who knows nothing about technology asks, for these to be recorded and in essence analyzed with AI?
Absolutely. And actually, having surgery recorded in general is a thing to look at safety of surgeons. And so sometimes, we do recordings and say, how could we do better? And I myself watch videos all the time, surgical videos of other surgeons doing things, and that's how we learn and that's how we progress. And I videotape my own cases and I review them and see how could I do better, what could I do differently. And so we absolutely do that.
So it would be recording that camera image, the 3D image that you're seeing?
So we de-identify the patients and we do it for education.
Got it. And when, because we also have a medical school attached to all this, so when you're doing these surgeries, are medical students able to watch along?
Yeah, our rooms are super high tech, and so not only can I see in the screen that's in my 3D console, but we have about 5 other screens up all over the room. So there's a really big screen on the wall, there are screens coming down from the ceiling, we have booms coming down so that everyone in the room, the anesthesiologist, our nursing staff, our students, our equipment specialists can see from any angle that you're sitting at in the room. You can see screens.
So the nursing staff, even though that may be somebody there for suction, can also look around and see the same thing that you're seeing?
Absolutely, as long as nobody brings junior mints.
No junior. Yes. Right. Okay.
I'm just kidding.
See,
no food in
somebody else who watches television.
Yeah.
All right. Do we have any questions? No questions. All right. Well, I got a couple more. So, if you are evaluating a patient and you're in, what would be some of those surgeries that may or may not be a robotic kind of surgery?
So for me, I do benign gynecology. So I do hysterectomies or any adnexal surgery, gynecologic surgery where there's no cancer. My colleagues do the cancer surgeries for the pelvis. And so that's my colleagues in GYN oncology. So for me, it would be patients with very large fibroid tumors. So sometimes their uterus has grown to about this big, so the size of a watermelon or the size of a cantaloupe. And so I tell them, look, I can attempt the surgery robotically, and 95% of the time I'm successful, but there are times where we're going to have to open and make a big incision. And so we talk about that up front.
Does that happen during the surgery where you're working on it robotically and you realize, no, we can't do it this way, we have to go back?
Yeah, very rarely, because we try to judge ahead of time what can we do and what can't we do. And with experience, I would extremely rarely open the patient, but we always counsel the patients so they're educated that that is a possibility.
And do patients actually get to see the robot? I know I didn't. Did they get to see the robot before the surgery?
You did, but you don't remember.
Yep. There's a lot
and
of
so,
it.
yeah,
Thank
so
goodness.
The patient rolls into the room and the robot is there.
Right,
and they often say, oh, that's the robot. And then they have medication on board that makes them forget, and that's part of the anesthetic. So most of them see it, you just don't remember.
I think in hindsight, I'd like to have met my robot. I think his name was Ralph.
I had one patient tell me, please don't give me any medicine. I want to see the robot and I want to remember.
Yeah, in hindsight, I really wish I would have seen it.
Yeah.
Yeah, that's very cool. Okay, so as your surgeons, your 20-plus surgeons that are trained, I imagine they have to continue training for a while.
Mm-hmm. Yeah, so we do, at UC Davis Health, we have proctoring and privileging. So we make sure that you're maintaining the adequate number of cases per year. And if you, let's say you were gone for a while, or you didn't have enough patients for a period of time to do robotic surgery, and you trail off, then we have you reproctored and retrained. And then in addition to that, every 6 months we do training for everybody, every 6 months, over and over again, for not just the surgeons, but our staff, our engineers, our equipment specialists, and our nurses and residents.
Okay. So, looking in your crystal ball, what's the next step in robotic surgery?
Well, I think that we want to proceed more with single port surgery. So ideally pioneer some more areas of single port surgery, some colon and rectal surgeries with single port, maybe gallbladder or some gastrointestinal procedures with single port. In the future, we'd like to pioneer some of those at UC Davis Health, in addition to generally natural orifice surgery, which would be very nice for patients, so no incision surgery.
Right.
And then way down the road, maybe AI.
Oh, okay.
Yeah.
I say, and build in cosmetic scars just so they can keep them.
So you can have bragging rights for your scars.
Okay. Well, that's the basics for robotic surgery. There'll be much more to come. I'm sure we'll be back with you, Dr. Nejad, sometime soon. Thank you for joining us.
Thank you.